Good evening, everyone. It's 5 minutes past the hour, and I think we can start so that we can catch up with time. So once again, I'd like to thank us all for joining this meeting. My name is Dr. Ademola De. I'm president of the Nigerian Society for Colorectal Disorders. And today we have a very interesting topic for presentation. The title of today's presentation is Secondary Metastasis to the Colon and Rectum. And our presenter is Dr. Ugwueke Francis. He's a consultant general surgeon from the University of Nigeria Teaching Hospital, Enugu. And he will be taking us through this very interesting topic. So as usual, please reserve your comments and your questions to the end of the discussion, and there will be opportunity to send your questions and comments both on the chat and by voice when we recognize your show of hands. This meeting is being recorded and will be available on our platforms at the end. And we look forward to a very interesting event. And without further ado, I hand over to Dr. Ugwueke to continue the presentation. Over to you, sir.
Thank you, sir. Good evening, distinguished colleagues, professors on the platform, and my trainers. I'll be leading today's discussion, Secondary Metastasis to the Colon and the Rectum. My name is Dr. Ugwueke. I'll start by taking the case presentation of one of my patients that we just managed recently. She's a 61-year-old lady diagnosed with invasive lobular carcinoma of the right breast in July 2024. The staging diagnosis was T2N1M0. She had an immunohistochemistry, estrogen positive, progesterone negative, HER2 negative tumor. Whole body CT scan done at diagnosis did not show any evidence of metastasis. We gave this patient, we started this patient on neoadjuvant chemotherapy with adriamycin-based chemotherapy, continued with docetaxel, which she took a total of 8 cycles, 4 each, with very good response. She had total mastectomy and level 2 axillary dissection. Post-mastectomy specimen of this patient did not show, it shows only reparative changes with only 1 out of 17 lymph nodes that was isolated from her axillary fat containing metastatic tumor. She was commenced on letrozole based on the estrogen positive tumor and scheduled for external beam radiation to the chest wall. However, she didn't get this because of financial constraints. So fast forward about 18 months later, after treatment, that's this month, about March 2026, she presented back to us with 3 weeks history of progressive abdominal distension and bilious vomiting and constipation, with associated paraumbilical biting colicky abdominal pain and passage of mucoid stool and borborygmy. She had no prior history of abdominal surgery. So she was acutely ill in respiratory distress, a febrile, pale, not pale and icteric. Her abdomen was grossly distended, tympanitic with hyperactive bowel sound. And rectal examination revealed good perianal hygiene, good sphincteric tone. The rectum contained scanty fecal matter with no masses, and the examining finger was stained with well-formed stool. These are the X-rays, plain radiograph of the abdomen of the patient, showing features of large bowel intestinal obstruction. So we made this impression of large bowel obstruction, but we weren't very sure. We were thinking, could this be a primary colonic tumor in the patient, because it had a classical features of large bowel obstruction, or could it be a volvulus? So at that time, we weren't thinking that this could possibly be a metastasis from the already treated breast CA. Sorry, my dog is disturbing us. Now, treatment, this patient was resuscitated and had an emergency exploratory laparotomy, had an ileostomy and biopsy of intra-abdominal tumor deposits at the mesoappendix and also had an appendectomy. Now, all this treatment is because of the intraop findings, which are as follows. We found a large bowel obstruction with markedly distended cecum and transverse colon. And tumor deposits were found at the transverse colon. Now, this was a major point that was causing an obstruction, but this tumor deposit was extending to involve the mesocolon and also the extending into the greater curvature of the stomach. And there were multiple tumor deposits at the mesentery of the small intestine as well, and at the mesoappendix, and moderate ascites. So based on this extensive tumor, we felt that this patient would better be served with an ileostomy because there were no places for us to put a colostomy. We didn't want to do anything that will cause more morbidity for the patient. So she did well and discharged in good condition. Now, post-specimen histology came out to show that sections of the mesentery, that's the mesoappendix, contained metastatic malignant epithelial proliferation made up of tubercles and cords of malignant cells with large pleomorphic hyperchromatic nuclei. So the pathologist concluded that this is a metastatic carcinoma with features compatible with metastatic breast CA. The appendix was largely normal, except that it contains some hematiasis. So, even though we've sent this tissue for immunohistochemistry and we are awaiting the results. Currently, this patient at discharge is ECOG 3, and we placed her on letrozole. Our further plan is to do an MDT once this immunohistochemistry comes out and decide on way forward for the patient. But in our mind, we are thinking of adding a CDK4/6 inhibitor, that's palbociclib. We are thinking that the patient, even if we add a chemo, maybe a mono chemotherapy will be useful because of the ECOG status. Well, I will be glad if in the course of our comments, if anyone can also suggest to us other things we can do for the patient. So going to the main meat of discussion this evening, which is a review article of a secondary metastatic lesion to the colon and rectum, a publication that was done at Annals Gastroenterology. So colorectal cancer, as we know, is a common neoplasia in the GI tract. Of course, the third most common malignancy worldwide, with an incidence approaching about 1.5 million cases annually. Now, it remains the third leading cause of cancer-related death. Now, but secondary metastatic lesion to the colon and rectum are generally uncommon. It's an uncommon entity with literature we reviewed showing that it's accounting for just about 1% of total colorectal cancers in available literature. Now, but post-mortem investigation in this my review article demonstrate that we probably have a greater occurrence than expected. Some of the studies that were done involving post-mortem has found out that this incidence is actually higher. So this is what makes this topic interesting for us. When we are handling malignancies and patients who have cancers, we must have a high index of suspicion because this may be more common than we think. So usually when there is secondary metastatic lesion, it usually comes from a known primary neoplasm, and some of the common organs from the review article is implicated is the lungs, the ovary, the breast, prostate, kidney, skin, or stomach, or hepatobiliary system. So in most cases, we have multiple lesions. However, 1/3 of them may still be asymptomatic and found only on autopsy. In fact, this review showed that about 1/3 of these metastatic lesions involving the colon are actually asymptomatic and only found on autopsy studies. So this slide shows us the main pathways of cancer metastasis: direct or local extension, lymphatic spread, hematogenous spread, or implantation spread. We will look at this in details when we look at the different cancer that spread to the colon. Now, the commonest pathway for metastatic spread to the bowel is through peritoneal seeding, and this is mostly implicated in ovarian cancer. Hematogenous or lymphatic dissemination have also been reported, and majorly involving the breast, the lungs, and melanoma from this review article. The clinical presentation of metastatic lesions to the colon are usually non-specific. They mimic the general symptoms that we may also see in patients that have colonic tumors. So some of them may present with bowel obstruction or GI bleeding or anemia or weight loss. Most times, it's important to know that exuberant symptomatology is usually uncommon in this patient, and that's why we need to maintain a high index of suspicion. Patients that will, even though my own patient presented with an acute abdomen, but this is usually rare. And when it occurs, it connotes a limited survival rate. So asymptomatic patients or those found in autopsy, I've said, occurs in 1/3 of cases of metastatic lesion to the colon. So these manuscripts we reviewed focused only on primary malignancies coming from the lungs, the ovary, the breast, prostate, kidneys, and melanoma. And their emphasis is on the frequency, clinical presentation, and the workup investigations for diagnosis only. So their materials came majorly by a search of the literature constructed using the PubMed to identify original studies and review articles involving metastatic lesion of the colorectum, the lung cancer, ovarian CA, breast cancer, prostate, kidneys, and melanoma. So we will just quickly look at briefly all these 5 major malignant conditions that was reviewed. Lung cancer is a leading cause of cancer-related death in men and second most common in women. Now, commonly, lung cancers do not spread. The common organs in which lung cancer metastasize include the thoracic lymph nodes, the liver, adrenal gland, brain, pleura, kidneys, and bones. But surprisingly, in autopsy studies of 423 patients, they found only 6 were found to have spread to both small and large guts put together. So there is no specific clinical features that is pathognomonic or that can help you link a lung cancer to the colon. So it is still general, non-specific symptoms of that is common with colorectal cancers. Bowel obstruction, perforation, GI fistula, microcytic anemia, bleeding, or rarely can have bowel intussusception. So when you have patients who are presenting with these symptoms, diagnosis is majorly by CT of the abdomen and colonoscopy with biopsy. Biopsy will help us make a histological diagnosis that we're dealing with malignancy, but immunohistochemistry is key in making diagnosis and differentiating metastatic from primary colonic malignancy. Now, the immunohistochemistry staining of a colorectal adenocarcinoma, classically we have the CDX2 positive cytokeratin 20 positive, and CD7 negative. This is what is found in the typical colorectal adenocarcinoma. So when you take a biopsy of a colorectal lesion and you now find out that the immunohistochemistry is staining positive for the thyroid transcription factor, that's the TTF1, and the CDK7 is positive, and CK7 is positive and CK20 is negative. That strongly suggests that the malignancy, or that confirms that the colorectal lesion that you are finding is a metastatic from a lung cancer, because this TTF1 is stained positive in malignant cells, in malignancies from the lungs. Now, as against the CK7 positive, which is usually negative for cancers originating from the colorectal lesions, and negative CK20, which is usually positive for cancers originating primarily from the colorectal. So the immunohistochemistry is a key differentiating factor in this lesion. Now, turning to ovarian cancer metastasizing to the colon, the incidence in this review article is put at 4 to 6% of cases. And the mode of spread, as we have noted, is usually from transcelomic spread, which is the chief, but it can still be by hematogenous. So clinical manifestations are also very, very non-specific. You can have abdominal discomfort, bowel obstruction, intussusception, or there may be a palpable abdominal mass, or it may not even be symptomatic in this patient. So diagnosis again in this will be relevant abdominal CT or an ultrasound, and colonoscopy with biopsy. Biopsy is what will confirm diagnosis, and immunohistochemistry is again a key differentiating factor in differentiating these tumors and being able to identify them. So we have, these are the tumor markers that need to be evaluated. The CA125 and CA199, CK7, CK20, estrogen, progesterone receptors. These are key in identifying the origin of metastasis. So specifically, if we have positive staining on immunohistochemistry for CK7 and CA125 and estrogen, progesterone receptors, these are considered indicative of a tumor from an ovarian origin. So if at colonoscopy and biopsy and immunohistochemistry, one finds positivity for CK7, CA121, that is pointing that the lesion is not primarily from the colon. So because why the immunohistochemistry is a key in this diagnosis of these malignancies, that you can still have the normal adenocarcinomas, and that can be confusing. So the other factors that can be stained, if we are having CK20 positive, CA, of course, that shows that is from the colon. So these are the differentiating staining immunohistochemistry features that will point to a metastasis. Now, this table shows the clinical characteristics of a published colorectal metastasis from primary ovarian cancer. Now, what's important in this table is that in as much as most of the diagnosis of colorectal metastasis from a primary ovarian cancers usually occurs maybe years, up to even 20 years after diagnosis of ovarian cancer. There are some that are being reported that can also occur, can be a synchronous lesion that is diagnosed at the same time you are diagnosing the ovarian CA. So once you watch out for this, and published studies have shown that this can also occur. And the commonest sites of metastasis is usually the rectum and the sigmoid colon for primary ovarian cancers that is spreading to the colon. So it's important that we note that. Now, for breast metastasis to the colon, which my patient had, this is also rare, and the incidents have been put at between 3 to 20% of cases in this review article. And they are, however, associated with extensive disease and poor survival rates. I just hope that this will not be the portion of my own patient. So, most common histopathological subtype of the GI tract metastasis seems to be invasive lobular carcinoma, which happen to be the same histological characteristics of my own patient presented. So, even though the invasive lobular carcinoma constitutes just about 5 to 15% of the total breast neoplasm, majority being the invasive ductal carcinoma, is interesting to note that most of the spread of cancers coming from the breast to the colon come from invasive ductal carcinoma, invasive lobular carcinoma, sorry. So we need to watch out for this, especially when we have a patient with invasive lobular carcinoma and the patient is presenting with GI symptoms. We need to screen properly for colorectal involvement. So the interval of diagnosis is usually put at by a review literature, reported literature, about 20 to 30 years, but this is not what it was found in my own patient. This occurred just within 2 years after treatment. Mode of spread for breast is majorly hematogenous in this case. However, peritoneal or lymphatic spread has also been documented. So clinical features are also non-specific and may imitate acute or chronic inflammatory process such as diverticulitis or inflammatory bowel disease, or may mimic primary colonic CA. So we need to bear that in mind. Diagnosis is by CT, abdomen, and colonoscopy and biopsy. Immunohistochemistry features of metastatic invasive lobular carcinoma include, now, when you have invasion and intramural infiltration throughout the submucosa and muscularis propria and serosa. Tumor cells growing in form called, that's the Indian files or small clusters. Some of them may appear as signet ring appearance, and absence of dysplasia or nuclear atypia in the colonic epithelium, and also presence of infiltrating tumoral cells surrounding the pre-existing glands. All these are histologic features that would point to an invasive lobular carcinoma metastasizing to the colon. However, the immunohistochemistry also remains the chief in nailing this diagnosis. So, staining with estrogen positive progesterone receptors where they are present, and the loss of expression of cell-to-cell E-cadherin is consistent with the unique dispersion pattern of lobular carcinoma in the case in which it is a lobular carcinoma. But this is in contrast to what is found in ductal carcinomas. Of course, if there is expression of HER2, cytokeratin, Ki67, P53, or histocytic markers, these are also helping to differentiate. So, the clinical characteristics of published colonic metastasis from primary breast cancer. We see that majority of the reported published data is incriminating lobular carcinoma, histologic type of breast, as the major culprit in spreading to the colon. The commonest sites involved are being displayed on the table. Ascending colon, sigmoid colon. Unfortunately, there has not been, from this review, none has been implicated in terms of transverse colon. Our own patient spread was involving majorly the transverse colon. And the number of months to diagnosis ranges from synchronous or 4 months to about 5 years. So now for prostate cancers that metastasize to the colon, the incidence of locoregional penetration by locally advancing prostate cancer has been reported to about 1 to 12% in this literature. This dissemination occurs through different routes. Can be from direct invasion through the non-villus fascia and rectal infiltration. It can also be by lymphatic spread through the common pelvic nodes and channels. Implantation along the needle biopsy tract in rectal and perirectal tissues have also been reported. So, vast majority of cases that have been reported involve metastasis involve the sigmoid and rectal and the rectum. Clinical presentation includes any possible manifestation of colorectal cancer. Please just give me a minute, let me open this. Sorry for the for that. Now, long intervals between initial. Now, one of the challenge of from this review, one of the challenge that of making a diagnosis, differentiating these two, is because of the close proximity between the prostate and the rectum makes diagnosis here sometimes difficult. And sometimes where there are long interval between the initial diagnosis of prostate cancer and metastasis to the rectum can throw a shadow in people making a wrong diagnosis of colorectal cancer, whereas a spread may be occurring from the prostate to the rectum. Most times the clinical features, the clinical presentation helps, the history of this patient helps in differentiating where this tumor is coming out from. Most times, of course, the symptoms that begin first, if you are having symptoms of rectal, colorectal lesion beginning first before a patient have symptoms of maybe bladder outlet obstruction, that can guide in knowing which of the cancers you are dealing with. For patients who have prostate cancer spreading to the rectum, the patient may have had signs and symptoms of prostate CA much, much earlier before coming down with symptoms of rectal tumors. But the histology is what holds the final say in differentiating, especially the immunohistochemistry, because some of them can still have, you can still have adenocarcinoma in two of the tumors. So presence of at least one prostate-specific marker, either the P501S protein or the prostate-specific membrane antigen, combined with the lack of markers of colonic differentiation. This is what helps us to differentiate which malignancy is spreading to which, because you can have rectal malignancy spreading to the prostate or the prostate moving to the rectum. Now, for renal cancers metastasizing to the colon, this is a big challenge because we have very limited data on these reports. The major target organ for renal disease spread is usually the lungs, the liver, the bone, and brain. We only have, from this review article, only fewer than 10 cases of secondary disease to the colon has been reported. So signs and symptoms is wide and roughly identical with that of colorectal cancers, including even GI bleeding. So as I said, there is no specific guideline from this review article that helps in differentiating, in making this diagnosis. So although a pathologic finding of late reoccurrence were reported to show some unique features and often associated with primary renal tumors of stage 2 and above being poorly differentiated. But for most of the tumors, which may be stage 1 or less, there is usually no clear guideline on the diagnosis. So therefore, we should have a high level of clinical suspicion to track colorectal metastasis of renal origin, because there are no